Okay, thank you. This is going to be case-driven. I need for you to use your clickers or your phones. I really do, because I want to have this case-driven. Now, tomorrow, I'm going to do cases on hypertension based on what we talked about on hypertension. But this is focused on heart failure. And, oh, good, it's working well. I want you to understand the Oh, by the way, there are many more slides in your handout that you will see than I'm going to cover. But the slides are very comprehensive. But I just didn't want to give you too much in this oral presentation. I think this will hit it. I want you to understand the epidemiology of heart failure, including its prevalence, the fact that it increases with age, and ethnic disparities. Describe the appropriate workup for patients with symptomatic heart failure, including when and how to use the biomarkers brain natriuretic peptide and pro-B type natriuretic peptide, NT-proBNP. Recognize the differing treatments for those with HFpEF and HFrEF, and recognize the newer treatments for HFrEF, including LCZ696, that's sacubitril and valsartan, and ivabradine. And be familiar with the updated 2017 guidelines on heart failure from the 2017 ACC-AHA Heart Failure Society of America guideline. Now, are you all familiar with the trade name of valsartan sacubitril? It's on TV almost every night, so that's one. And do you know the trade name of ivabradine? Yes? Corlinor? That's the only time I'm going to mention that. And the trade name of valsartan sacubitril is Entresto. Okay? We're not going to call it that anymore. We're going to refer to it by its generic combination name. Good. Okay. So the purpose of the 2017 focused update is to update the 2013 ACCF Foundation AHA guideline for the management of heart failure. The scope of the focused update includes revisions to the sections on biomarkers, updates on HFpEF, new therapies indicated for stage C symptomatic heart failure with reduced EF, covered in the 2016 focused update, new insights regarding the prevention of heart failure and new blood pressure targets. We talked a little bit about that yesterday. And new data on important comorbidities, including sleep apnea and anemia. I'm not going to discuss that much, but I do have that a little bit in the summary slide at the end. Okay. So first pre-test and only pre-test question, because we're going to do cases. On a scale of 1 to 5, please rate how confident you would be in the evaluation and management of patients with heart failure. And please answer now. Not at all confident. Thank you. Slightly confident, moderately confident, pretty much confident, or very confident. Okay, moderately confident looks like it's winning, and we will continue. Okay, we'll get back to that at the end. Okay, the definition of heart failure. Heart failure is a complex clinical syndrome that can result from any standard structural or functional cardiac disorder that either impairs the ability of the ventricle, what we have called systolic heart failure, or fill with restriction, preserved diastolic heart failure, or eject blood. But the bottom line is all heart failure leads to a reduction in cardiac output. The cardinal manifestations of heart failure are shortness of breath and fatigue, which may limit exercise tolerance and fluid retention, which may lead to pulmonary congestion and peripheral edema. Heart failure pathology may affect heart size, wall thickness, and ejection fraction from a normal heart to HFpEF in a hypertensive, often women more than men, elderly, who have a very thickened left ventricle with concentric LVH from hypertension, or from an idiopathic dilated cardiomyopathy with a HFrEF, heart failure with reduced EF. But we'll talk about this as we go through the cases. Now, 1 in 5 of us in this room are likely to develop heart failure in our lifetime. And once heart failure is diagnosed, we are doing all we can with all we have in our armamentarium to change the natural history of the disease. But most people who develop heart failure will die of heart failure or something else. It has a combined mortality worse than all forms of cancer combined, heart failure. About 6.5 million patients in the US, 20 years of age, suffer from heart failure, and 23 million worldwide. As of 2012, 2.4% of the US population was reported to have heart failure. The number will surpass 10 million by 2037. It's the leading cause for inpatient hospitalization in the US, and it accounts for 70% of the total healthcare cost of heart failure. Most of us will be diagnosed within 6 months of the end of our life with heart failure, and the average cost per individual is $156,000 in that last 6 months of life. The total cost of heart failure is projected to grow from $44.6 billion in 2015 to $97 billion by 2030, with 53% of the cost due to hospitalization. Thus, the real emphasis on reducing recurrent hospitalization within 30 days of a previous heart failure hospitalization. The natural history of heart failure. About 20% of patients with heart failure die within the first year of the diagnosis, while 50% die within 5 years of the diagnosis. 35% with class 4 heart failure die within 1 year. So it's a very important problem in a primary care practice. If you look at the prevalence of heart failure, you can see that it increases with age, and we're all living longer. Within each 10-year age increase from 65 to 85 years, heart failure incidence doubles in men and triples in women. Next slide. Because I'm so interested in hypertension, which often allows people to either have or be diagnosed with heart failure with preserved ejection fraction, please notice that because of the risk and the greatest risk of hypertension for developing heart failure, blacks have a greater risk than whites of developing heart failure, and this will continue to 2030 because of hypertension and the development of HFpEF. Others and Hispanics you can see here. Next. We need to distinguish, and we will during the talk, what we referred to in the past as systolic heart failure, which is now HFrEF, okay, where the ejection fraction is less than 35 to 40%, and preserved EF, so-called diastolic abnormalities. But by clinical trial enrollment, we've always defined these patients by their ejection fraction. So because we've defined them by their ejection fraction, we're calling them either HFrEF, less than 35 to 40%, or HFpEF, normally at least 70% ejection fraction, but for clinical trial basis, 50% or greater. Next. Once cardiac output is decreased with heart failure from any etiology, a number of adaptive compensatory mechanisms are put into motion as an adaptive response to the abnormal insult. Reduction in cardiac output, sympathetic nervous system, beta-1 effect, increasing heart rate. The higher the heart rate, the greater the mortality. As heart rate increases 5 beats per minute over 70 in those with heart failure, their risk for cardiovascular death and total death increases. Alpha, vasoconstriction. To try to preserve preload and cardiac output, vasoconstriction occurs to preserve blood pressure. So you've got the increase in heart rate, you've got the increase in alpha tone. The renin-angiotensin-aldosterone system. Angiotensin II, vasoconstriction. Aldosterone, salt and water retention, all trying to preserve cardiac output. The natriuretic peptide system, including bradykinin, adrenomedullin, but also, as you know, atrial natriuretic peptide in the atria, B natriuretic peptide in the ventricle, and C natriuretic peptide in the endothelium. And all of these natriuretic peptides are trying to preserve vasodilatation and natriuresis, antifibrosis, and antihypertrophy. So they're all adaptive initially, but then they become maladaptive. For instance, BNP, the first 32 amino acids are what's biologically active favorably in BNP, but we use BNP as a biomarker. And as BNP gets greater, it loses its biologic activity. The new drug, sacubitril, which is a neprilysin inhibitor, helps, we believe, restore biologic activity in BNP. So you would think, well, why don't we do better with a very high BNP? Because it loses its biologic activity. So we use beta blockers. We use renin-angiotensin ACE inhibitors and ARBs. We use mineralocorticoid receptor blockers. We use neutral endopeptidase and neprilysin inhibitors for benefit in our armamentarium. And what a difference we have today from what we had in the 70s with all the clinical trials that shown a benefit, predominantly in heart failure with reduced EF, where the evidence base is much greater than heart failure with preserved EF. We have a staging system for heart failure, A through D. A and B asymptomatic, C and D symptomatic. And here are the staging systems of heart failure from 2003, which is still pertinent today. You can see that stage A is where we try to prevent heart failure. And prevention of heart failure is no more important than it is today. And we'll talk a little bit about that in a minute. In terms of the prevention of heart failure, we have RAS blockers and we have diuretic therapy. In hypertension trials, in the ALL-HAT trial, the secondary endpoint of first evidence of clinical heart failure was significantly reduced more with chlorthalidone than with other therapies. Now, remember, in ALL-HAT, patients were on previous therapies and then they were withdrawn and they were double-blindly randomized to chlorthalidone, lisinopril, doxazosin, or amlodipine. And for prevention of heart failure, chlorthalidone was unsurpassed in a secondary endpoint of clinical heart failure than the other strategies. So perhaps RAS blockers and thiazide diuretics, chlorthalidone preferred, are best for the treatment of hypertension in patients not yet diagnosed with hypertension. Once they have structural heart disease, like post-MI, we use ACEs and beta blockers, and that is shown in these boxes. And I know that it's a little hard for you to see, but you can see the goals of therapy. Okay, so once they have structural heart disease, post-MI, it's an ACE or an ARB and a beta blocker, as long as they're hemodynamically stable. We have the greatest evidence once they develop symptomatic heart disease in stage C, and we're going to talk about this as we go along, but I just want to refresh this for you. We're going to control symptoms, and we're going to use the evidence-based strategies that improve outcome in patients with symptomatic heart failure with reduced EF, and we're not going to talk very much, and here are the therapies: diuretic for fluid retention, an ACE or an ARB, beta blocker, mineralocorticoid receptor antagonist, and then in selected patients, and I'll talk about this, hydralazine isosorbide. We don't use much DIGs today, but it still can be used in low dose, but we have other therapies that really have advanced the outcomes and improve the outcomes for heart failure with reduced EF in symptomatic heart failure. And then I'm not going to talk about hospice and advanced care. I'm not going to talk about device therapy, which can be very, very effective implantable cardiac defibrillators, as well as cardiac resynchronization therapy. But I want to stay mostly on prevention and treatment with drug therapy. We use the same, in the 2017 guideline, the same evidence base with class and level of evidence as we do for the hypertension guideline and previous guidelines. And so you can refer to this at a later time. Okay, so there's a new section in the 2017 guideline, and the reference is down there. You just can't see it because the slide, it cuts it off. But there's a lot to talk about in terms of prevention in heart failure. If we can control diabetes, obesity, and hypertension, we can reduce first incidence of heart failure by 50%. Diabetes, obesity, and hypertension. Remember, as a class of evidence, recommendation 1, and from the SPRINT trial, where we double-blindly randomized people with automated oscillometric blood pressure detection to less than 120 versus less than 130, we reduced first evidence of clinical heart failure by 38%, almost 40%. So in the new guideline, they talk very, very rigorously and emphatically in patients at increased risk, stage A heart failure, asymptomatic but at risk. The optimal blood pressure in those with hypertension should be less than 130 over less than 80. This is a new recommendation, reflects the SPRINT trial and the 2017 hypertension guideline. Okay. In patients with heart failure, in terms of treating symptomatic heart failure, that was for prevention of heart failure. In patients with stage C symptomatic heart failure with preserved EF, level 1, limited data. C, patients with heart failure, preserved EF, persistent hypertension, and after management of volume overload should be prescribed guideline medical therapy titrated to attain systolic blood pressure less than 130. This also is a new target. So for prevention and treatment, less than 130 over less than 80. Next slide. You're going to have to help me on this. Okay, let's talk about the serial evaluation of heart failure. There is no difference, no change in the workup of the patients with Class C symptomatic heart failure. And all of these are Class 1 recommendations. A history and physical, family history in patients with dilated cardiomyopathy. Could they have a familial cardiomyopathy? Weight and volume status, CBC, urinalysis, electrolytes, lipids, liver panel, TSH. EKG, chest X-ray. A two-dimensional echo with assessment of left ventricular systolic function, a BNP or N-terminal BNP to assess the likelihood of heart failure in those ambulatory with dyspnea or acute decompensation when the etiology is uncertain. More to follow. Repeat measurement of LV function only when a significant change in clinical status has occurred. So we don't get repeated BNPs and N-terminal pro-BNPs. We don't get serial echoes unless it can help us change how we approach the patient's management. Biomarkers. BNP and terminal pro-BNP are both derived from pre-pro-BNP, which is generated by cardiomyocytes due to stretch, pressure, and volume. They increase with not only cardiac diseases, but also age, female gender, African American race, chronic kidney disease, and other conditions. Next slide will show you that more. Go back one, please. Low levels can rule out heart failure. BNP, N-terminal pro-BNP, is a great negative predictive test. If low, you're not dealing with clinical heart failure. So 98% rule out the diagnosis at a BNP less than 80. High levels have good positive predictive value for the diagnosis. Heart failure is very likely at a BNP greater than 500 or an N-terminal pro-BNP greater than 1800. But it's not as good as a positive predictive test as it is as a negative predictive test. Sort of like a D-dimer in DVT. Strong predictors of mortality at 6 months. I'll show you that in a minute. Morbidity and mortality is shown to increase when the pro-BNP is greater than 500, correlates with New York Heart Association class, intraventricular pressure, pulmonary pressure, and it's inversely proportional to cardiac output. The higher the BNP, N-terminal pro-BNP, the lower the cardiac output. Treatment. Levels generally fall with treatment, but in 2 trials that have tried to look at the ability of BNP or N-terminal BNP to improve outcome over guideline-directed medical therapy, they were not able to show that. So at the current time, the use of serial BNP and pro-N-terminal BNP is not recommended for day-to-day therapy of patients with heart failure. There are cardiac and non-cardiac causes of elevations in BNP and N-terminal pro-BNP. Pre-pro-BNP is broken down to pro-BNP, which then either is broken down into BNP or N-terminal pro-BNP. Pick one or the other as a serial marker for you to follow. But as I'll show you, if you use sacubitril valsartan, you cannot use BNP as a serial marker because it's a substrate for neprilysin, and when you inhibit it, BNP goes up. BNP cannot be used with sacubitril valsartan, so you have to use N-terminal pro-BNP. These are very effective vasodilators, decreased sympathetic tone, decreased aldo, decreased fibrosis, decreased hypertrophy. And of course, broken down into inactive fragments, and that's where the neprilysin inhibitor comes in. But there are cardiac and non-cardiac reasons for elevations in BNP and N-terminal proBNP. Thus, it's not as good as a positive predictive test as it is when it's a negative predictive test with levels less than 50 to 80 of a BNP. It's an excellent predictor of mortality at hospital discharge over the next 6 months. So it's very nice if the patient is tuned before discharge to get either the BNP or the N-terminal proBNP. And in this large study of patients at discharge that got a BNP, if the level was less than 350 at follow-up of 6 months, the risk of either an event or, it's hard for me to see that. It's either death or readmission for hospitalization for heart failure, it was reduced 15.2-fold, highly statistically significant. So the BNP on discharge, or the N-terminal proBNP, very helpful for predicting risk. So here's from the 2017 updated guideline. You're all aware of some of this data, but this is a new recommendation. It's a 2A recommendation. So they believe that it's going to be more beneficial than harmful. And what they're saying is if you recognize an asymptomatic individual, you may consider BNP or N-terminal proBNP as a means of stratifying risk for the development of heart failure. But 2 trials, the STOP Heart Failure and the Pontiac trial only in diabetics, have both used this as discriminators to predict patients' natural history in heart failure, and they haven't been able to predict it as well as we would have liked. So it's still unclear if you should be using a BNP or N-terminal proBNP in patients that are asymptomatic with risk factors for the future development of heart failure. On the other hand, the Class 1 recommendation goes for all patients that are now symptomatic, ambulatory with new onset dyspnea, very helpful, or Class 2 to 4 heart failure, or they have emergency room presentation with acute dyspnea. So both in the ambulatory patient in your office that has new symptoms of shortness of breath, you're unsure what the etiology is, you're unsure what's going on, you may get a BNP or an N-terminal proBNP, certainly for the diagnosis if they're first presenting with symptomatic signs and symptoms of heart failure, but also in the emergency room. And if they're hospitalized, we're going to recommend the same thing, or if they have Class 2 to 4 heart failure. Now, these are 2A and 2B other biomarkers for prognosis and risk development, and there's more in your handout on this, but at the present time, I don't think most of us are going to be using these in a primary care practice, but we will be using it as an initial diagnostic strategy to differentiate the signs or symptoms that may be heart failure, and as a follow-up in patients with either an acute on chronic presentation or at hospital discharge. So, in terms of the prevention of heart failure, for patients at risk of developing heart failure, natriuretic peptide biomarker-based screening followed by team-based care, including a cardiovascular specialist optimizing guideline-directed medical therapy, can be useful to prevent the development of left ventricular dysfunction, systolic or diastolic, or new onset heart failure. But notice, it's a 2A recommendation. New data suggesting that natriuretic peptide biomarker screening and early intervention may prevent heart failure. But stay tuned. 2 trials have looked at that, haven't been able to show it. Okay, so we're going to move on. Next slide. Okay, we talked about that. We talked about that. Okay, first case. 75-year-old white woman here for follow-up. She has a history of diabetes, hyperlipidemia, and hypertension. Has mild shortness of breath when walking from the car to the church. She's gained 15 pounds over the past year. She was hospitalized due to poorly controlled hypertension and heart failure 8 months ago. No history of coronary disease. 1 pillow orthopnea, frequent ankle swelling. Her echo shows a normal left ventricle, EF 70%, and LVH. Currently, she's on amlodipine 5 a day, valsartan 160 BID, atorva 20, aspirin 81. Physical exam, blood pressure 145/90, pulse 68, weight 285, no JVD, lungs are clear, cardiac regular rate with a positive S4, abdomen soft, non-tender, extremity 2+ with bilateral ankle edema. Her EKG shows LVH by voltage, otherwise unremarkable. Which of the following is the most reasonable approach? And we're going to go to the question. Make no changes, add metoprolol tartrate 50 BID, add ivabradine 5 BID, add digoxin, or add furosemide 40 BID. So we don't have many people. 5 people have answered. Show of hands. How many people think it's A, make no changes, B, add metoprolol, C, add ivabradine, add digoxin, add furosemide? Okay. I think the best answer is add furosemide, 40 BID. Dyspnea and edema in an older woman, recent hospitalization for uncontrolled hypertension and heart failure, consider HFpEF, ejection fraction 70%. Clearly, randomized clinical trials have not shown survival benefit with any particular drug therapy in patients with HFpEF. We need to control blood pressure with careful diuresis to control symptoms of edema and or relieve shortness of breath. It is very hard clinically to differentiate patients with HFpEF from HFrEF. There are some soft findings that can help you differentiate it. But in general, you're going to need an echocardiogram to get the ejection fraction. And in general, HFrEF is heralded by an enlarged heart, perhaps an S3 gallop, and HFpEF is associated with an S4 and a narrow cardiac size. But otherwise, it is very difficult to differentiate because when they present to the emergency room, they have the same cardinal manifestations in signs and symptoms of presentation. And they include pulmonary rouse, fluid overload, dyspnea on exertion or at rest, PND, inability to sleep or daytime fatigue, loss of appetite from gut edema, and difficulty concentrating, reading, and calculating. In terms of HFpEF, it is responsible for 30 to 50% of heart failure cases, and, which have normal systolic function. The risk factors are advanced age, hypertension, diabetes, the presence of LVH, coronary disease, and it is more often seen in women than in men. Diastolic heart failure has a predilection for women. It accounts for half of the hospitalizations with heart failure, occurring mostly in the elderly, primarily women, and the mortality rate is half that of systolic heart failure, but 4 times that of persons without heart failure. When you look at different registries, including the Framingham Heart Study, the Mayo Clinic in Olmsted, CHS, HMO and calcium, Medicare calcium, and the Duke registries, you'll see the prevalence is about 50% of all heart failure. Next. When you look at the natural prognosis and the history over years of follow-up, you see that systolic heart failure has a much worse prognosis than those without heart failure, but here is diastolic heart failure. So it has a death rate of about half that of systolic heart failure. Next. When you look at admissions for heart failure, it occupies about 50% of all admissions for heart failure. Next. And when you look at the type of patient that presents with either HFpEF or HFrEF, here's a typical patient with HFpEF, long-standing hypertension, often elderly, with concentric LVH. We'll talk about why this occurs in a minute, versus someone with either an ischemic or non-ischemic, as in shown here by cross-section, dilated cardiomyopathy. Large intracavitary diameter, very short and small intracavitary diameter, and here is a normal heart. Now, why do people with HFpEF present with shortness of breath, left-sided heart failure, crackles, rales, and then edema from right-sided heart failure? So it's Saturday. All of us are interested in the big football game, so tonight we're going to have some brewskis, a little potato chips, some salt and water, excess. But we are going to sense when our diastolic volume goes up, we are going to sense that we have to go to the bathroom, and we are going to go and relieve the excess fluid volume that doesn't allow us to get short of breath from an elevated left ventricular end diastolic pressure. This is a normal Frank-Starling curve. On the other hand, patients with left ventricular hypertrophy have a thickened, restricted left ventricle, and for the same amount of, or even less volume, as shown here, they develop symptoms of shortness of breath and left-sided heart failure when they have the same amount of volume and salt and water retention. So that often is the reason why patients present to the emergency room with signs and symptoms of heart failure from volume excess when they have underlying hypertension and LVH. Next. So why do they decompensate? Why do these people with HFpEF decompensate? Well, they take in excess salt, they develop new onset atrial fib, they now are put on NSAIDs or calcium channel blockers that have a negative inotropic effect, inadequate diuretic therapy, worsening hypertension, superimposed myocardial ischemia, worsening renal function, iatrogenic volume overload, or anemia. So these are all things for us to think about why our patients with long-standing hypertension and HFpEF may present with decompensated heart failure. When you look at the evidence base, and we'll go through this with HFrEF versus HFpEF, we have many studies since 1986 showing isosorbide hydralazine better than an alpha blocker or placebo. Then enalapril better than isosorbide hydralazine. ACE inhibitors better than placebo. ARBs better than placebo. ACEs and ARBs sort of similar. Mineralocorticoid receptor antagonists in the ROUSE trial better than placebo with spironolactone. Mineralocorticoid receptor antagonists with eplerenone post-MI better than placebo. A lot of evidence base for ACE or ARB, beta blocker, mineralocorticoid receptor antagonists, but almost no evidence base for a difference between an ACE or an ARB and placebo, or adding a mineralocorticoid receptor antagonist in the TOPCAT trial over placebo in patients with heart failure with preserved ejection fraction, symptomatic heart failure with HFpEF. Next slide. So in terms of the management of HFpEF, the treatment is directed at the signs and symptoms, the hemodynamics, and the etiology. And here's what we say in the most recent 2017 ACC-AHA hypertension guideline. In adults with HFpEF who present with signs and symptoms of volume overload, diuretics should be prescribed as a treatment for hypertension. And as I told you in the ALLHAT trial, I believe chlorthalidone was superior, of course, to the other comparative agents, ACE, CCB, alpha blocker. Now, as also a class 1 C limited data, adults with HFpEF and persistent hypertension after management of volume overload should be prescribed an ACE or an ARB and a beta blocker titrated to attain a systolic pressure of less than 130. That's a new guideline. In appropriately selected patient, and this is from the TOPCAT trial, with ejection fraction greater than or equal to 45%, elevated BNP levels, or heart failure admission within the last year, all parameters of TOPCAT, with spironolactone. Estimated GFR greater than 30, creatinine less than 2.5, potassium less than 5, aldosterone receptor antagonists might be considered to decrease hospitalizations. And then also as a 2B, the use of ARBs might be considered to decrease hospitalizations for patients with HFpEF. So the bottom line is treat heart failure, treat hypertension before they get heart failure, and try to prevent HFpEF, but once it develops, there's diuretics with a class 1, there's an ACE or an ARB and a beta blocker, and then there is a softer recommendation for a mineralocorticoid receptor antagonist. And then there are some harms, nitrates, phosphodiesterase inhibitors, and the routine use of nutritional supplements is not recommended for patients with HFpEF. So we don't have the evidence base of HFpEF as we do with HFrEF, and we'll talk about some other cases that will illustrate that. This is a 68-year-old African-American woman for follow-up, history of non-ischemic cardiomyopathy and hypertension, frequently has to rest during daily housewife due to shortness of breath, has one pillow orthopnea, was hospitalized 6 months ago for heart failure. No history of CAD when cathed 1 year ago. Echocardiogram 6 months ago with a dilated left ventricle and an ejection fraction of 30%. Currently on valsartan 160 BID, carvedilol 25 BID, furosemide 40 BID, Spiro 25 a day. She had angioedema to enalapril. Currently, her physical examination, blood pressure is 125 over 80, pulse 62, weight 255, no JVD, lungs are clear, cardiac regular rate, grade 2 over 6 systolic murmur, thought to be a flow murmur, abdomen soft and non-tender, extremities with 1+ edema. Okay. So, which of the following is the most reasonable approach in this patient? Make no changes, add enalapril 10 BID to valsartan, add ivabradine 5 BID, add isosorbide dinitrate hydralazine, or discontinue valsartan and add sacubitril valsartan 24-26 milligrams now. So, let's see if we can do this. Okay. Okay, so the most, even with the history of angioedema, right, you're saying that E is the best answer for this patient. Let's go on to the next slide. And I thought the best answer was add isosorbide dinitrate hydralazine. So this is an African-American woman with HFrEF that's on good background therapy, and the question is what to add next. E would not be the correct answer because she has angioedema. C3 would not be the right answer because her heart rate is less than 70. But I think 4 is the best answer. The patient has persistent symptoms of New York Heart Class Association 3 heart failure despite optimal neurohormonal blockade with an ARB, beta blocker, and an MRA. Combination isosorbide dinitrate hydralazine should be added, and isosorbide hydralazine is the best evidence-based guideline treatment that is recommended at this time for this African-American patient with New York Heart Association Class 3 HFrEF. When you look at all of the major trials and the benefits in HFrEF, you see that mortality, total mortality, is reduced with an ACE inhibitor, a beta blocker, a mineralocorticoid receptor antagonist, and with hydralazine nitrate. Now, this here, the 43%, I'll show you, is from the AHEF trial, the African American Heart Failure Trial. But since 1986 until recently, we've had tremendous expansion of our clinical evidence base with either an ACE or an ARB, but not both, a beta blocker, mineralocorticoid receptor antagonist, either spironolactone or eplerenone, and hydralazine nitrate in all patients over placebo, but enalapril was better than hydralazine nitrate in all patients. But in the AHEF trial, African Americans with HFrEF, hydralazine nitrates was extremely effective. Why? Because we believe they have a reduction in nitric oxide production, which this potentiates. We know the evidence with ACEs or ARBs, okay? We have multiple trials. The beta blockers, when I went to medical school, we were taught beta blockers are contraindicated in heart failure, especially when there's a reduction in EF. But as I told you, that adaptive, which becomes maladaptive pathophysiology, is now broken up by effective beta blocker sympathetic nervous system tone reduction. We have evidence with long-acting metoprolol succinate, ceiling dose 200 milligrams per day, mean dose 169 milligram in a patient, over placebo, 34% reduction in death. Bisoprolol used in Europe, 1 to 10 milligrams, reduction in death. And Copernicus, which was done with carvedilol, BID, generic carvedilol, 35% reduction in death. These 3 beta blockers are evidence-based beta blockers that should be used in patients with heart failure with reduced EF, in all patients on an ACE or an ARB, or if there's a contraindication to an ACE or an ARB. And basically, we have tremendous evidence for blocking the sympathetic nervous system and the renin-angiotensin-aldosterone system with these agents that I've just talked about. And we have some evidence that fixed-dose combination isosorbide dinitrate hydralazine is better than placebo, but not better than enalapril, BID, and in African Americans is better than placebo when added to good background therapy. We are going to talk about the use of neprilysin inhibitor, but we can't talk about it with an ACE inhibitor, and I'll show you that in a minute, but we will talk about it when it's added to an ARB. So, back to our patient. In our patient, she's an African American with class 3 heart failure. She is still symptomatic. She's on an ACE and a beta blocker, an ARB and a beta blocker, and the class 1 level of evidence A recommendation is to add hydralazine and a nitrate. And that comes from the AHEF trial. This was to demonstrate the safety and efficacy of isosorbide dinitrate hydralazine compared with placebo in African American patients with moderate to severe heart failure concurrently receiving standard heart failure treatment. They were self-identified African Americans, New York Heart Association class 3 or 4 for at least 3 months. The EF was less than 35%, or if they had a dilated cardiomyopathy, it could be less than or equal to 45%. They were on good background of therapy, and I want to show you that background of therapy. 94% were on diuretics, 78% were on ACEs, 28% were on ARBs. 87% were on beta blockers. Interestingly, 62% were on DIG, and 39% were on spironolactone. And then they were double-blindly randomized to isosorbide hydralazine or placebo. And here in this 2004 study in the AHEF trial, the conclusion of fixed dose of isosorbide dinitrate plus hydralazine to standard therapy for heart failure, including neurohormonal blockers, is efficacious and increases survival among black patients with advanced heart failure. And here is the Kaplan-Meier curve of total mortality. The primary endpoint was a composite score, all-cause mortality, first heart failure hospitalization, change in quality of life for 6 months relative to baseline. But in terms of total mortality, 43%, highly statistically significant decrease in the 1,050 patients studied. Not only was all-cause mortality significantly reduced, but first heart failure hospitalization and quality of life was improved in these African Americans with class 3 and 4 heart failure with HFrEF on really good background therapy. So in the 2013 guideline, not to be changed in the 2017 guideline, the combination of hydralazine and isosorbide dinitrate is recommended for African Americans with New York Heart Association class 3-4 HFrEF on guideline-directed medical therapy. And a combination of hydralazine and isosorbide can be useful with HFrEF who could not be given an ACE or an ARB because of drug intolerance, hypotension, or renal insufficiency, and that was a 2A. Although isosorbide hydralazine comes in a fixed-dose combination, which was used in this industry-sponsored trial, you can also use generic hydralazine and isosorbide dinitrate, but here you have to give it 3 to 4 times a day, and here it was given in a fixed dose of 37.5 hydralazine, 20 of isosorbide, 2 tablets 3 times a day, for a maximum dose of 225 of hydralazine and 120 milligrams of isosorbide. Okay, let's move on to case 3. 56-year-old white male here for follow-up. History of dilated cardiomyopathy with EF of 28%. Generally doing well, but continues to have shortness of breath when climbing 2 flights of stairs. No history of CAD. He continues to have increasing orthopnea. Blood pressure 110/70, heart rate 59. No JVD, lungs clear, no S3, no edema. Currently on lisinopril 40, carvedilol 12.5 BID, Spiro 25, and Lasix 20 BID. Blood pressure 110/70, heart rate 59 per minute. No JVD, lungs clear, cardiac regular rate and rhythm, abdomen soft, non-tender, extremities without edema. Which of the following is the most reasonable approach? Make no changes. Add valsartan 40 BID to the lisinopril. Add ivabradine 5 BID with a heart rate of 59. Add digoxin or discontinue lisinopril at 40 and add sacubitril valsartan 4951 milligram BID in 36 hours. So please answer now. All of these cases have little intricacies to them. Perhaps ethnicity, perhaps heart rate, perhaps background of therapy. What's the next best thing to do? Okay, so very good. E is the best answer. Discontinue lisinopril, but wait 36 hours and add sacubitril valsartan. Because he's on 40 of lisinopril, you can go to the intermediate dose of sacubitril valsartan, 4951 BID, and in 2 to 4 weeks you'd up-titrate to the 97 102 dose. Just very quickly, what's going on with sacubitril valsartan? Well, neprilysin is basically sacubitril is given as a prodrug, which then is broken down and antagonizes the effect of neprilysin, so that we believe that the active fragments of BNP and N-terminal BNP are more active and can be more effective for vasodilatation, natriuresis, antifibrosis, antihypertrophy. But when you antagonize the natriuretic peptide, neprilysin, you increase angiotensin II. And back in the day, that's why the Octave trial and the OPERA trial in hypertension and heart failure, respectively, had an ACE with a neprilysin inhibitor, not as specific for BNP as sacubitril. But angioedema was the problem back then, and it was never brought to the market. Well, here the increase in angiotensin II requires it to be given with a RAS blocker, but here we're using the ARB, valsartan, with sacubitril. So it blocks both the breakdown of BNP, but it also, by giving the valsartan, blocks the effects of the upregulation of angiotensin II. Okay, next. So neprilysin breaks down several endogenous vasoactive peptides, including natriuretic peptides. Inhibition of neprilysin potentiates the action of these peptides. Angiotensin II is also a substrate for neprilysin, so when you inhibit it, you have an increase in angiotensin II, so you have to combine it with a RAS blocker. Here, there was a problem both in Overture and Octave with angioedema, so we give it with valsartan as a first-in-class ARB neprilysin inhibitor with a lower risk of angioedema. And this was published in 2014, and this is the Paradigm trial. Mean age about 64, 1/5 women, 60% ischemic cardiomyopathy, heart failure with reduced EF, mostly class 2 and 3. There were some class 4 heart failure, but mostly 2 and 3. Here are the blood pressures. Here's the N-terminal pro-BNP, the B natriuretic peptide, diabetes, DIG, and their background of therapy. So Paradigm was a multi-center randomized double-blind parallel group active controlled study of the efficacy and safety of sacubitril valsartan compared with enalapril at 10 BID for reducing morbidity and mortality in patients with chronic heart failure and reduced EF. To get into the trial, the patients had to have class 2 to 4 heart failure and a reduced EF, HFrEF, and they had a BNP of 150 or greater or an N-terminal BNP of 600 or greater at screening, or a BNP of 100 or an N-terminal BNP 400 with hospitalization for heart failure in the last 12 months. And then they were single-blindly up-titrated for tolerability of enalapril up to 10 milligrams twice daily for 2 weeks. Then for about 29 days, sacubitril valsartan for tolerability, and they up-titrated it to the highest dose. 20% of folks were lost during the up-titration. And so here's the 20% of folks from the original single-blind run-in for tolerability, making sure our patients could tolerate these drugs. and then they double-blindly randomized them to either sacubitril/valsartan or enalapril. Median follow-up was 27 months. The trial was stopped early because patients on sacubitril/valsartan had a significant, with a favorable NNT, reduction in cardiovascular death and in heart failure hospitalization. In addition, they had a favorable reduction in total mortality, and they had a favorable reduction in heart failure death and in sudden death. Can you do that for me? Okay, and you see that there. What would this accomplish? In this model, epidemiologic model, a 55-year-old would have a projected life expectancy of an additional 1.3 years if they were on sacubitril/valsartan rather than just continued on their ACE or their ARB. And the reference is there. Next slide. When you look at the results in terms of safety, you had a little more hypotension with sacubitril/valsartan, but less hyperkalemia, less acute kidney injury, and less cough. No difference in discontinuation, less discontinuation for renal impairment, and no statistical difference in angioedema. However, 0.4% of patients on sacubitril/valsartan had angioedema, 0.2% of patients on enalapril 10 BID had angioedema. That's 2 per thousand different. But in the black population, 2.4% of the blacks had angioedema, and 0.5% of non-blacks had angioedema. So a little more risk, as we know, in blacks than non-blacks, but no difference between the overall population on sacubitril/valsartan versus enalapril. Next. So here's what they said in the updated guideline. The clinical strategy of inhibition of the renin-angiotensin system with ACE inhibitors, level of evidence A, or ARBs, level of evidence A, or sacubitril/valsartan, level of evidence BR, in conjunction with evidence-based beta blockers and aldosterone antagonists in selected patients is recommended for patients with chronic HFrEF to reduce morbidity and mortality. Next slide. Specifically about the ARNI, it did not get a 1A as the ACE or the ARB got, but it got a one randomized trial. So the ARNI got a BR in patients with chronic symptomatic HFrEF, class 2 or 3, because there were very few patients with 4, so they said 2 and 3, who tolerate an ACE or an ARB. Replacement by an ARNI is recommended to further reduce morbidity and mortality. And that's what you saw in the trial. This is a new clinical trial data based on paradigm that necessitated this recommendation. ARNI should not be administered concomitantly with ACE inhibitors or within 36 hours. That's why we waited on the lisinopril 40 36 hours before starting sacubitril/valsartan. And because the patient was on a good dose of an ACE inhibitor, we started at the moderate dose of the sacubitril/valsartan. The ARNI should not be administered to patients with a history of angioedema. That's why it wasn't the correct answer in the earlier case, where the patient had a history of angioedema. And this slide shows you why you don't use BNP as a target in patients on sacubitril/valsartan, because as a substrate, it will be increased when you inhibit BNP, sacubitril, when it inhibits neprilysin, BNP goes up. So you can use, and you should use, N-terminal pro-BNP as your marker in patients on sacubitril/valsartan. So it's FDA approved to reduce the risk of cardiovascular death, hospitalization for heart failure in patients with chronic heart failure. You start with 49/51 twice daily, double to the target dose of 97/103 twice daily after 2 to 4 weeks or as tolerated. If they are ACE or ARB naive, or those on low-dose ACEs or ARBs, severe renal impairment or moderate hepatic impairment, you start with 24/26, and then after 2 to 4 weeks, you uptitrate to the moderate dose, and then you uptitrate to the ceiling dose. 36-hour washout period is required of switching from an ACE to sacubitril valsartan. It is a replacement and not an add-on to an ACE or an ARB. And if they get pregnant, they're breastfeeding, or they have acute decompensated heart failure, we wouldn't use this drug. This is for either mostly ambulatory, stable chronic heart failure who may be on an ACE or an ARB or unable to tolerate an ACE or an ARB, who have symptomatic heart failure, class 2 and 3. The problem is the price, but this is an evidence-based drug, and we should be able to get this medicine. This is $375 medical letter a year ago plus per month. But most people should be able to get this evidence-based drug. Okay, and finally, class 4. This is a 76-year-old white male, history of CAD, status post-CABG, ischemic cardiomyopathy, HFrEF, severe COPD with frequent use of inhalers, comes to see you following a recent hospitalization for decompensated heart failure. On lisinopril 40, metoprolol 12.5, that's the maximum dose tolerated, aspirin, atorvastatin, and an albuterol inhaler. 118/80, pulse is 85, weight is 205, no JVD, scattered wheezes in the lungs, presumed from the COPD, cardiac regular rate and rhythm, no murmurs or gallops, soft non-tender, no edema, sinus rhythm with non-specific ST wave abnormality. Which of the following is the most reasonable initial approach? Make no changes, stop lisinopril and switch to enalapril, add ivabradine, add isosorbide dinitrate hydralazine, discontinue lisinopril, and add sacubitril valsartan 24, 26, and 36 hours. This is interesting. Okay, let's move on. I don't want to keep you too long. The answer is add ivabradine. This is a patient with COPD who has an intolerance to higher doses of beta blocker, who has a heart rate above 70. The patient has relatively high resting heart rate. As I told you in one of my earliest statements, when the heart rate each 5 increment over 70, the natural history of these patients incrementally gets worse. The scattered wheezes are likely related to the COPD, may be exacerbated by higher doses of metoprolol. So what's the best treatment option for this HFrEF patient intolerant to increases in beta blocker dosage with a high resting heart rate? It's ivabradine. Ivabradine is a specific inhibitor of the funny channel of the sinus node pacemaker, lowering heart rate without affecting blood pressure or other ionic currents. It's a pure heart rate reducing drug approved in 2015. It basically blocks phase 4 depolarization of the action potential, and it's responsible for pure heart rate reduction. In this SHIFT trial, 2010, large numbers of patients with HFrEF, EF less than or equal to 35%, prior heart failure hospitalization within 12 months, heart rate 70 or greater, and sinus rhythm were double-blindly randomized on background of therapy to ivabradine 5 BID or placebo, and they could be up-titrated or reduced depending on what happened to the heart rate. The primary endpoint was cardiovascular death, heart failure hospitalization. They had to have a heart rate 70 or greater in sinus rhythm, like our patient, with HFrEF, like our patient, with or with prior hospitalization within 12 months. Oh, sorry. The primary endpoint was significantly reduced, but it was reduced because of a reduction in hospitalization for worsening heart failure. There was no difference in cardiovascular death. Hospital admissions for worsening heart failure with ivabradine was significantly reduced. All-cause mortality, the second component of the primary endpoint, was not reduced. In patients receiving at least 50% or more of the target beta blocker dose, our patient was only on 12.5, no significant benefit was seen. So in patients that can be up-titrated on a beta blocker and heart rate reduced, this isn't a drug you would use, okay? And when you look at the doses, they were on 90%, 89% were on in both groups a beta blocker on entry, but of those that received at least 50% of the target daily dose of the beta blocker, only 58% were able to achieve that. Next slide. And 26% were on a targeted daily dose. So what did the guidelines say? Ivabradine can be beneficial to reduce heart failure hospitalization for patients with symptomatic class 2-3 stable HFrEF who are receiving guideline-directed medicine, including a beta blocker at maximum tolerated dose, and who are in sinus rhythm with a heart rate of 70 beats per minute or greater at rest. So this is another target in patients with HFrEF. And then finally, this is hard for you to see, but class of evidence 1 in patients with HFrEF from top to bottom include an aldosterone antagonist, continue the ACE or ARB, and then discontinue the ACE or ARB, initiate the ARNI, hydralazine isosorbide, and we didn't talk about an ICD or cardiac resynchronization therapy. Ivabradine has a class 2A recommendation, not a 1 recommendation, but all these have a class 1 recommendation. So heart failure has a high morbidity and mortality, which is improving. Hypertension is the most likely risk factor to be associated with heart failure, usually seen with HFpEF. We'd like to prevent heart failure. We have a new target of less than 130/80. Current treatment of heart failure is both empiric, diuretics, lifestyle, especially for HFpEF, and evidence-based ACEs or ARBs, beta blockers, MRAs for HFrEF, and MRAs for HFpEF. Newer therapies, including ivabradine and valsartan sacubitril, have been approved for HFrEF and have now been added to our significant evidence base earlier for outcome improvement. And let me tell you that valsartan sacubitril is looking at HFpEF in an effort to improve its outcome, because here we're using both neprilysin inhibition and valsartan, and people are very excited about this, so stay tuned. That'll be coming out in several years. Comorbidities are important. Anemia is often from iron lack anemia. It's recommended that you give IV iron, not oral iron. We don't use servo control support for central sleep apnea. CPAP only should be used for obstructive sleep apnea. Sleep studies are indicated in people with heart failure, especially if they have symptoms of sleep apnea. While there's no impact on heart failure outcomes, sleep quality is improved. All from the guideline. There's a new target of less than 130 for prevention of heart failure. Prevention is a new reality. And with that, just let me know on a scale of 1 to 5, please rate how confident you would be in the evaluation and management of patients. And just by a show of hands, how many are not at all confident? Slightly confident? Moderately confident? Good. Pretty much confident? Wow. And very confident. Okay. This has been a lot of material in a very short amount of time, but I've tried to differentiate some of these strategies with the new guidelines. I hope it's been helpful. I'm going to stick around. I want you guys to take your break.